Welcome to the deep dive, where we take the densest source material, and today it is an entire anatomical chapter on the largest abdominal organ, and really just pull out the essentials for you.
That's right.
We are jumping right into the liver, using chapter 66 of Gray's Anatomy as our only guide.
And it's a dense map. Our mission today is to translate all those complex diagrams, the vessels, the microanatomy, all of it, into something you can actually visualize. A sticky guide.
And we're moving from that traditional, almost academic view of the liver.
Yeah, to the modern functional view, the one that actually matters in clinical practice, especially for surgeons.
Okay, so let's start with just the sheer scale of this thing.
Yeah.
We are talking about the body's largest abdominal organ.
It's massive. It completely dominates that upper right quadrant. We're talking the right hypochondriac, the epigastric regions. It even tapers over into the left.
And it's heavy, right?
It is. In an infant, it can be 4 or 5% of their total body weight. In an adult, that settles down to about 2%, but its bulk really reflects its massive responsibilities.
And those responsibilities go way beyond just being a filter.
Oh, far beyond. It's the central processing unit for your entire metabolism. I mean, think about it. Massive detoxification, tight control over your blood sugar and lipids, synthesizing nearly all your clotting factors.
And it's a major source of body heat.
A huge source. You're looking at an organ that is in a state of continuous, non-stop activity.
All right, let's try to build a mental model of it. Since we can't hold one, let's start with the external geography. It has that classic wedge shape, correct?
It does. It fits perfectly right under the dome of the diaphragm. And we can really divide its exterior into two main surfaces.
Okay.
The first one is the diaphragmatic surface. It's that huge, smooth, continuous part that covers the top, the front, and the right side. It's convex, perfectly shaped by the diagram above it.
And there's a little dip on top for the heart.
Exactly. A shallow little thing called the cardiac impression, right, where the heart rests on it from above.
Okay, so that's the smooth top. Now let's flip it over to the underside, which is, well, a lot busier.
That's the visceral surface. It's shaped entirely by the organs it's pressed against. It's irregular because of all the impressions they leave.
So what are its main neighbors down there?
Well, starting from the right, you've got the right kidney and the suprarenal gland, then the top part of the duodenum, the right colic flexure.
So the bend in the colon.
Right, and then finally the stomach. The shape is literally a map of the organs it sits on.
And separating that busy underside from the smooth top is a really distinct edge, the inferior border. Why is that so important in a physical exam?
Because it's the only part you can really get your hands on, so to speak. Normally it's tucked up under the ribs. But if you ask a patient to take a deep breath...
The diaphragm pushes the liver down.
Exactly. It pushes it down. And a clinician can then palpate that inferior border to check if it's enlarged, for hepatomegaly.
A great clinical tie-in. Okay, now, let's get to the anatomy everyone learns first year, the 4 traditional lobes.
Ah, yes. The big right lobe and the smaller left lobe. This division was based purely on what early anatomists could see, the external fissures and ligaments.
And the other 2, the quadrate and caudate lobes, are on that underside we were just talking about.
They are. If you find the porta hepatis, that deep central trench where everything goes in and out, the 2 smaller lobes kind of bracket it.
So anterior to the porta hepatis is the quadrate lobe.
Correct. It's bordered by the fossa for the gallbladder on one side and the fissure for the round ligament on the other.
And that round ligament is a remnant of the fetal umbilical vein.
The left umbilical vein, yes.
Yeah.
Then if you swing around to the posterior side of the porta, you find the caudate lobe.
Okay.
It's tucked between the fissure for the ligamentum venosum, another fetal remnant, and the deep groove that holds the inferior vena cava, the IVC.
So historically, these were just seen as parts of the big right lobe.
They were because of how the peritoneum folds. But as we're about to see, functionally, that is completely wrong.
Right, that's the big shift. But before we get functional, how does this heavy organ even stay up there? The peritoneal attachments.
The ligaments are crucial, and the most interesting feature they create is the bare area.
Which is called that because it has no peritoneal covering.
Precisely. The peritoneum reflects off the liver onto the diaphragm, creating the coronary ligament, but where its layers spread far apart, they leave this large triangular patch of liver directly attached to the diaphragm with just connective tissue. It's a major anchor point.
And the most obvious anchor, from the front at least, is the falciform ligament.
Yes, attaching it to the anterior abdominal wall, and running inside its free edge is that round ligament we just mentioned.
Now, this is where fetal anatomy makes a dramatic comeback in pathology.
It really does. So that round ligament is the leftover of the fetal umbilical vein. It's closed off. But if a patient gets severe portal hypertension,
say, from cirrhosis.
Exactly. The blood backs up and tries to find any possible detour around the liver. And sometimes that long closed-off round ligament reopens.
It actually becomes a channel again.
A collateral channel, yes.
Right.
Blood shunts down it into the veins of the abdominal wall, causing them to swell and dilate around the umbilicus.
And that's the classic sign, caput medusae.
That's it. A porto-systemic shunt, visible right on the patient's abdomen. A direct link to their fetal past.
Incredible. Okay, now let's talk about the highway into the liver, the lesser omentum.
Right, and specifically its free edge, the hepatoduodenal ligament. This is the protective sleeve that carries the portal triad up to the porta hepatis.
Okay, so this is the moment. We have to make the big paradigm shift from the lobes we can see to the segments that actually work, the functional architecture, or Kunoa's classification.
We have to, because if you're a surgeon, you need to remove diseased tissue while keeping the healthy parts alive. And that means following the internal plumbing, the blood supply, and the drainage.
So it's a map based on perfusion, not appearance. How does it start?
It starts by splitting the liver into right and left hemilivers. The dividing line isn't the falciform ligament you see on the outside. It's an internal plane, the main portal fissure, or Cantley's line.
And where does that line run?
Imagine a plane going from the middle of the gallbladder fossa on the bottom, straight back through the liver tissue toward the IVC. That's the split.
And what crucial vessel runs inside that dividing plane?
The middle hepatic vein. This is the most important concept. The three major hepatic veins, right, middle, and left, are intersectoral. They run between the functional sectors, defining them.
So the surgical principle is to cut along those planes.
To avoid hitting the major drainage trunks. It's brilliant. This divides the liver into 4 sectors, and then further into 8 segments, I through 8.
Let's talk about segment 9, the caudate lobe. You called it a rebel earlier.
It is the functional rebel of the liver. It sits way back there, posterior, and it gets blood from both right and left portal systems. But its venous drainage is totally unique.
It doesn't use the 3 main hepatic veins.
Not at all. It drains directly into the IVC through its own set of small, short veins. It's completely independent.
That has to give it a huge survival advantage in certain diseases.
A phenomenal advantage. Think about a condition like Budd-Chiari syndrome, where the main hepatic veins are blocked. The rest of the liver is congested, dying.
But segment I is fine because its drainage is separate.
It's spared. And what's more, it often compensates. It undergoes hypertrophy, it gets bigger to try and take over the function of the struggling liver. It's an incredible design.
Wow. So for a surgeon, maybe doing a lap col, are there any external landmarks that can help them navigate this internal map?
There are a few. The umbilical fissure, where the round ligament sits, is a pretty good surface marker, separating segment 3 from 4.
Okay.
But on the right side, the structure called the fissure of Gons, or Rouvier's sulcus, is a really helpful landmark on the undersurface. It often marks where the portal pedicle to the right posterior sector enters. Very useful.
All right, let's follow that pedicle in. The triple blood flow. At the porta hepatis, how are the duct, vein, and artery arranged?
The spatial orientation is very specific, and you have to know it. The hepatic ducts are most anterior, so they're in front. The hepatic portal vein is the most posterior structure.
And the artery?
The hepatic artery and its branches are nestled right in between the two. Duct front, vein back, artery middle.
Okay, the hepatic artery. It brings the oxygenated blood. You mentioned variations are common.
Common is an understatement. They're almost the rule. Up to a third of people have a significant variation. You might see a replaced left hepatic artery coming off the left gastric artery, for instance.
Or the big one, a replaced right hepatic from the SMA.
Exactly, from the superior mesenteric artery. And knowing that variant isn't just academic trivia, it can be life-saving.
Why is that? What's so special about its path?
Because when that right hepatic artery comes from the SMA, it takes a different route. It travels posterior to the portal vein and the main ductal system.
Ah, so it's out of the usual line of fire.
Precisely. If a patient has a tumor at the hilum, like a cholangiocarcinoma, it often encases the standard anteriorly located artery. But if they have this replaced posterior artery, the tumor might not have reached it.
So an anatomical anomaly suddenly makes an inoperable tumor operable.
Potentially, yes.
Yeah.
It's a perfect example of why this anatomy is never just theoretical.
Unbelievable. Now for the main inflow, the hepatic portal vein, it brings, what, about 75% of the blood?
About that, yes. It's nutrient-rich blood from the gut, but it's low in oxygen. It's formed behind the pancreas by the superior mesenteric and splenic veins joining up.
And it stays in that posterior position all the way up.
All the way. Now, once all that blood mixes in the liver, it has to get out through the three major hepatic veins.
Right, middle and left.
And just to hammer it home one last time,
Yeah.
they are intersectoral. They run between the segments, draining them as they head straight for the IVC.
Okay, last stop on our tour. Let's zoom all the way into the microstructure. We hear about the classic hepatic lobule, but you said the liver sinus is the more functional unit.
Because the classic lobule is just a structural hexagon around a central vein. The acinus is organized around the blood supply, the incoming portal triad. This lets us understand acinar zonation.
So the liver tissue isn't all the same, it's zoned.
Not at all. It's a gradient. Zone 1 is periportal tissue, right next to the fresh, oxygen-rich blood. It's built for high-energy jobs. Zone 3, on the other hand, is perivenous. It's the furthest away, right next to the central vein where blood drains out.
Getting the leftovers, oxygen-wise, I bet that makes it vulnerable.
Extremely vulnerable to hypoxic injury, but it's also packed with the most powerful detoxification enzymes, like the cytochrome P450 system. Its job is to do the final cleanup before the blood leaves the liver.
And I remember there's a countercurrent flow here.
Yes, blood flows inward toward the central vein, while the bile that's produced flows outward toward the bile ductules in the portal triad, opposite directions.
And where does that critical exchange between blood and cell actually happen?
In the parasinusoidal space, or the space of Dissy, it's a tiny little gap between the hepatocyte itself and the lining of the capillary, which is full of pores. Plasma flows right through and bathes the liver cell.
And a very important cell lives in that space, right?
The most important cell for chronic liver disease, the hepatic stellate cell, normally just sits there, quietly storing vitamin A.
But when it gets angry.
When it gets activated by chronic injury or inflammation, it transforms. It starts churning out collagen, and that's the scarring, the fibrosis that we call cirrhosis. They are the engine of fibrosis.
Which brings us perfectly to our last point, pain. Why is liver damage so often silent?
Because the liver tissue itself, the parenchyma, doesn't have sharp pain receptors. Any pain from swelling is a dull, poorly localized ache, referred to the epigastric region, like other foregut organs.
So the sharp pain comes from the capsule around the liver.
Exactly. Stretching or irritating the fibrous glissons capsule, that causes sharp localized pain because it's supplied by intercostal nerves.
Okay, last question. The classic referred shoulder pain. What is the mechanism there? Why the shoulder?
That's all about the diaphragm. If you have pathology on the superior surface of the liver, it can irritate the diaphragm right above it, and the diaphragm is innervated by the phrenic nerve.
Which originates in the neck. C3, C4, C5.
Right, and those same nerve roots, C3, C4, C5, also supply the skin over your shoulder. So your brain gets this pain signal from the phrenic nerve and misinterprets it, thinking it's coming from your shoulder.
A fantastic mechanism. We have covered a huge amount of ground here. We went from the external surfaces and traditional lobes.
Right, left, caudate, quadrate.
To the internal functional map that actually matters. Kuno's 8 segments, all defined by those hepatic veins running in the fissures.
And we saw that vascular variations are the rule, not the exception, and that the microscopic zonation is the key to the liver's function and its pathology, thanks to those stellate cells.
That functional independence, like the caudate lobe's private drainage system, is just so elegant.
It is. And that leaves us with a final provocative thought for you to take away. We know the liver is incredibly resilient. It can regenerate. And a lot of that resilience comes from the functional independence of its segments and its dual blood supply. So as bioengineers work towards growing new livers, how much of their success will depend on perfectly recreating not just the cells, but the entire microarchitecture, the acinar zones, the vascular independence that we've detailed today.
Thank you for sharing your source material for this deep dive into the anatomical basis of clinical practice. We hope this visualization guide serves you well.